Hi everyone, welcome to this closure of the guest Caliper series about aortic root management. We have this panel, luxury panel, with us to discuss everything about aortic root management. So we have Mara Ouzounian from Toronto, Ismael El-Hamansi from Mount Sinai, Juan Pablo Maña from Colombia, but now in Cleveland, Florida, Dr. Boyan from Michigan, Dr. Alberto Forteza from Madrid. And I'm Lorna Montes, I'm the cardiac editor for CTSNet. So let's start. So the first video we published this week was a Bentall in an 80 years old patient with aortic regurgitation, and it was made by Mara Ouzounian. So I want you to comment a little bit about this patient, about this technique.
Thanks for the question, and thanks for the invitation to do this series with CTSNet. I think the choice in an 80-year-old about whether or not to do a valve sparing versus a Bentall is an important one, but mostly I would say that it has to really be individualized to the patient. A healthy 80-year-old with normal heart function, normal kidneys, no coronary disease, I think can have a valve sparing route if the valve looks good. Once you get into the low ejection fraction, kidney problems, coronary disease, that's when I think, a Bentall is going to serve this patient just fine for the rest of their life, and I wouldn't push it in a patient who has comorbidities. What do others think?
I agree with you 100%. I mean, I don't think we should practice age discrimination when it comes to reconstructive valve surgery, meaning if the patient is 70 but otherwise healthy, I think we should consider valve preservation or even a Ross procedure. We will get to that point eventually. But just like we do with mitral valve repair, nobody would ever question repairing a mitral at age 70. But again, you have to be smart about it. If the patient is a little sicker, if the valve is not perfect, it has to be a definitive operation as best as possible. And so I think what you did is exactly what should be done.
Right.
So you want to
No, I agree. I think that a couple of questions I would pose is how aggressive should you be in an 80-year-old with a dilated aortic root? And from what size on would you actually go ahead and do in an 80-year-old with impaired kidney function and decreased ejection fraction? How aggressive are you when addressing the roots?
In the absence of aortic regurgitation?
Or in the presence of. I mean, if you have this same patient with a root that's 45 millimeters, would you go ahead and replace the aortic root or 48 millimeters?
Right. Your question's interesting. I think the indication for surgery becomes more meaningful as we get older in terms of just elective prophylactic aortic repair. I'm much more inclined to operate if there's significant AI or more, a valvular lesion to not a small aneurysm in an 80-year-old. There, we don't. I personally wait a little bit longer for the aorta in an 80-year-old. But if you have a valve indication and the root's close to over 45, I would do the root if they're coming for the valve.
Actually, the WTSA and Dr. Norton from Emory presented the data, the combined Columbia Emory about Dilated procedure. How old is too old? They did a very nice article study. 65 above, they found out the increased mortality, average mortality for the valve sparing. However, that group people sicker or have comorbidity, those things, just like your patient. I think you made a great decision to do about Bentall for your ED or the guy with kidney problem and other problems. I would do the Bentall too.
So there's another video about a chrysalis technique in another Bentall. And so in these Bentalls, I would love you to tell us how do you manage coronary button, tips and tricks to avoid ischemia, to avoid kinking. I think that's important for our viewers.
I would make a comment actually because we had just written episode of my colleagues actually did have coronary buttons from Bentall, just about Bentall, and they found out that lower part of left coronary button was actually left too much tissue was folded and pushed on the left button, and when we found when my colleague told me that might be the reason. When I trim the button at the bottom of left coronary button, I trim the small, make the stitches going actually close the orifice of the orifice of left coronary artery for all my roots. I think that prevents if too much tissue at the lower portion of the orifice of left coronary button, it can fold it and push on the left coronary button. That's very important. And don't mount it too high, then because that. If you use Valsalva graft, can bulge out, push on the left coronary too.
I think that's very important. The other thing I do to prevent kinking is I do not mobilize the button itself or the coronary itself. I peel the aorta off of the coronary, as you've taught me. So dissecting the aorta off of the coronary as opposed to the coronary off of the aorta prevents that mobility of the button. Eric Rosselli, for instance, does a square button so that you have a perfect orientation every time. I have an issue with the corners, but the sutures and the stitches going into the ostium all the way to the aorta coronary junction, as it were, I think is key.
Yeah, it's very good.
And how do you manage it in redo Bentall? Because that is very challenging. Everything is like completely fixed in there. You cannot mobilize it normally. How do you manage that?
No, I think these are challenging. In a primary Bentall, I do the similar way, like it's a rectangular division of the coronary. Initially, mobilize the aorta away from the coronary and then stay close to the inside of the coronary and to keep the orientation. In a redo, this is the most challenging portion of a redo Bentall, likely, is managing a redo coronary button. And I think one of the key things is just to ensure you're understanding for the left, for example, where the PA is coming off of, mobilizing as much as you can around the button, and then leaving a little bit of tissue around it at the beginning. But if you leave too much, I had one last week where the buttons were very hard, and if you leave all of this rigid tissue, it's just not going to be hemostatic. So just cutting close into the orifice of the coronary and being very gentle with it. Of course, if you are in a salvage situation and it's fixated, you can do a Cabral, but I try to avoid doing that.
I agree. Absolutely, I agree with you absolutely. I think if you can avoid a Cabral, it's much better, because you can have problems about kinking of the graft. Sometimes it's difficult to decide the place of the graft in Cabral procedure, but sometimes it's the only option for the patient also, this technique. But ideally, it's better to...
If you take your time and just work on the button, I think you can avoid it most of the time.
Yeah, I mean, frankly, I think cabrals can be avoided in all redo root surgeries. Of course, there will be maybe one case or two cases in practice, but the reality is it's you have to understand anatomy, like Morales said, to work all the structures away from the left button. So you work the PA away from the top of the left button, you work the aorta away from the PA on the medial side, and then on the surgeon side, there's really nothing that obstructs. You can just cut down to the level of the roof of the left atrium, and then to the right PA, and that just creates enough mobility that the graft will go to. You don't need the left main to be flopping in the air. You just need to bring the graft to it. And if you really think that you have a lot of distance, a Valsalva graft can be helpful in reaching to the coronary, but most of the time you're fine. And the right is pretty simple to isolate as well. And the worst that can happen is that you'll injure the RV, or that can be easily fixed. It has to be recognized at the time of mobilizations, particularly underneath it. Just fill the right ventricle to make sure that you don't see any bleeding from. But otherwise, it's a very rare situation, in my opinion, where a Cabral should be used for coronaries.
My preference in mobilizing the coronaries in redos, as well is I find it hard to dissect from the outside, and what I usually tend to do is go on the surgeon side, on the right side of the left coronary button, and start the section from inside with a 15 blade until you get to the fat. Once you get to the fat on the outside, then you usually find there's a space down there, right? You usually have a lot of adhesions at the top. Whereas if you and then you core it out and telescope it, and again, I knock on wood, I've never had to do wrong in a redo situation, and yeah, a Valsalva graft will usually get there, which is probably something we should talk about with that Chrysalis.
I do agree. I have not done a single topographic redo roots, and it's always able to dissect out the buttons. And one thing is, if the patient had a mechanical graft there, save a rim of graft and sew your graft to graft, they don't need to sew to the tissue anymore because the previous graft was sewn tissue full thickness. So that's a trick.
Yeah, and I think a good trick in redo situations where the patient had the previous valve implanted, and sometimes there's very little space between the rim of the valve and the bottom of the coronary, is when you open the aortic root, forget the valve. The general tendency is to go, let's remove the valve first, and then you cut yourself short below the coronary. Leave everything there, start carving the coronaries out, take all the tissue you need underneath it at this moment with a 15 blade, mobilize the coronary, and then work on getting that valve out. Because the whole operation is about the coronaries. It's not about getting the valve out, you can implant in the LVOT if you need to. But the coronaries, this is really where the success of the operation. So don't leave that last in your cleaning up of the root. Start with the coronaries, make sure that you have ample tissue around them, that you mobilize them correctly, and then get the valves out and do your operation. Would you agree with that?
Yeah. That's very, very good. It's much more important than focusing. The valve's going to come
Correct.
out.
Yeah.
I think everyone just goes
For the valve. Whereas you leave the valve last. Actually start with the coronaries.
The tissue is destroyed.
Correct, yeah.
What can I do? Okay. Another thing that is very important in all root management is hemostasis. So you were talking about the right ventricle when you are dissecting that way, and it starts bleeding in that place. How do you manage hemostasis in these aortic root procedures?
I mean, I just give cardioplegia. After the whole root's mobilized, I give ostial cardioplegia to see what's going on. Sometimes under the left main, there's those tiny little branches. Make sure you're dealing with it before you reimplant the valve or do anything. Leave blood behind, make sure the RV is okay, and then I think that's basically it. Yeah.
All of you use cardioplegia to see if it's bleeding in there to prove everything or not?
So I use retrograde for all my aortic cases only. It's all retrograde, and I don't do that part as you do, but retrograde can tell us the venous bleeding. Sometimes I check. I think the bleeding part is your suture line has to be watertight. I inspect from in. I do not use what is the connector? I don't use that. I make my own Valsalva graft with Valsalva graft with valve inside. I can opticize 2 to 3 valve size if the root is small. So that the color portion of the graft to the root, it's very flexible, and I see from inside, it makes it really tight, makes no gap or anything. It's very hemostatic. I think the suture, meticulous suture line is very important for that part of bleeding.
When would you use a pre-made valve conduit versus an LVOT custom Bentall? When would you use it?
I think I do a custom-made LVOT Bentall with a Dacron in the LVOT, mostly when the annulus is disrupted and it's endocarditis and you have no good annular tissue and you need to go deep. And then it's quite simple. You just take a graft and sew it inside. That has to be hemostatic, and then implant the valve inside. But yeah, otherwise for a mechanical Bentall or the bio, we use the pre-made ones. We used to sew them in, but yeah.
Okay. So there's another video about a David procedure performed by Dr. Alberto Forteza from Madrid. And this is a Marfan patient, a young patient. And you actually have a lot of patients with Marfan, right? You have a unit just for Marfans. So
yeah.
Can you tell us a little bit about this video, this procedure?
We have a unit for Marfan patients, and I think this operation for Marfan is probably the best option because it stabilizes all the components of the aortic root. You don't have to do annuloplasty or other techniques. Just with David procedure, you can stabilize all the components. So in this case, it was a young patient with no aortic regurgitation and some fenestration in the leaflets, but near the commissures. So this was not a problem, and the patient didn't have aortic regurgitation. And we did a David procedure with the Stanford technique with 2 grafts. The first larger graft just to be more comfortable doing the reimplantation of the aorta, and the second graft just to conform the sinotubular junction.
Okay, so I saw there was a big fenestration, and it was like a concern. When do you touch this fenestration, and when do you say no? Let's leave it alone. It's not going to affect anything.
Yeah, I think I don't know what the rest of the panel think about the fenestration, but in general, if you try to touch fenestration in Marfan patients that they have very thin leaflets, probably this valve is not going to be preserved. So for us, the best option in Marfan is to leave the fenestration in place, just and don't touch. Do you think?
Who touches fenestration?
If it's not that big small, I would not touch it because you will see the homograft come out have fenestration too. The engineer make it competent fenestration. It's not uncommon to see in those valves. If it's large fenestrations, if it's not good, that's right, savable and salvageable. I would just replace the valve. Yeah.
I agree. Thin, small commissural fenestrations, I usually don't touch. I find that if you do, you create more disruption than you did, particularly in a normally functioning valve. Fenestrations that concern me are the ones that are these long, almost cords, strings that go and attach to the center of the valve or close to the nodulus of our branches. Those concern me. I think those need to be addressed either with a patch or replacing the valve, as you said. But those I've seen those fail as you change the stresses on the valve. Those can rupture and you get acute AI early on, or making the operation last a lot less than it should.
Yeah, I think I agree with Juan Pablo. I mean, again, it's judgment. It's how big the fenestration, but it's really, to me, it's not the size of the fenestration. It's how the leaflet is held to the commissure. And if it's just a string that is holding the leaflet to the commissure with absence of any material underneath, I worry about those. Because we know that in an aortic root, the area of highest stress is the pericommissural area. And so now you have a rigid graft instead of a compliant aorta. So there's even more stress transmission to the leaflets. And if it's just holding by that string, it can tear or rupture. So it's a judgment call. I don't like to put patches, like you said, because then you're just opening it up for really just unpredictable behavior. It can fail very quickly or not. But often enough, these patients are young. The alternative is not great because you don't necessarily want to do a ROS, so you end up with a mechanical or a tissue Bentall. So I think it's probably worth preserving the majority of these valves. But if you do so, you will have the scenario that Juan Pablo just described. You will have a patient come back with acute AI, which often enough can be very poorly tolerated if the patient had no AI before the initial operation. So it's a judgment call, right? I mean, I have replaced some of these valves on occasion when I felt very uncomfortable leaving that string. I don't know what your thoughts are.
No, I think we've moved in general away from repairing fenestrations and these Gore-Tex suture lines or patches. And I think especially if the valve is competent before, ignoring these I think is best. And then it's just a judgment call, or is it too much? Is it all three cusps and these giant long strings, or are they just small things at the corners and you can ignore? But I think in that situation, it's really dependent on the age of the patient, and if you can, I think you will have some come back potentially if you save these like big long strings, but in some patients, like overall, it might be worth it. They're young enough.
Yeah, and one more comment about this. We didn't see any patient in more than 150 Marfan patients in which fenestration played a role in valve function. So I think that the most important fenestration is be very careful and don't increase the holes, because in that case,
don't make new pathology.
So how do you calculate the measure of the root? Because there's many different ways to formulate it.
In real world, we don't.
We
don't calculate with just formulas and. I think one thing is real world, other thing is the courses, and in our case we use a large graft, so the size of the graft is not a problem. In most of patients, it's 32, 34, depend of the diameter of valsalva sinuses. And we only have to decide the size of the annulus, because the size of the valsalva sinuses and the size of the sinotubular junction. But in most of cases, it's a 32 millimeters graft.
And the other graft will be
28 in most cases.
It's very interesting because now many people use the Stanford modification. I was trained at Stanford, so I do exactly what you just described.
Yeah.
Large graft, plaquette, and then use small graft STG reconstruction. I do measure the height, geometric height of the cusp. I find out that if that small leaflet is shortened, it could be a problem for the competence of the valve. If it's too short, like for tri-leaflet valve, tricuspid aortic valve, is less than 17 or 18 millimeter, you need to be very careful. And for bicuspid, the 20 is pretty cut off, and I have now need to replace the valve after David, except the one that cusp was 16 millimeter. I found out I still had mild A. I just replaced it. I'm not sure what the experience. I do measure the geometry of the root.
Okay. How about you?
I measure the height of the left lung and correlate that with the diameter of the annulus plus 5 millimeters. It's usually, and that's what I usually go for or go by.
I measure the height of the left non and also the geometric height of the cusps, and if they're smaller, if they're really marginal, 16, 17, we're going to go smaller. If they're bigger, we'll go bigger. But I just do a straight graft, and generally, all these formulas are sort of, they're more complicated than they have to be. It's not that complicated. If you have, like most people are going to get 28, 30. If you're bicuspid, it's going to be bigger because the annulus, the annulus is pathological. I don't actually go by the size of the annulus. I'm looking at the size of the geometric heights of the leaflets and how it's going to sit inside the graft. So most of the bicuspid valves will be big because the reference cusp is quite, tall, and the bicuspids will be 32, 34, and the other ones will be, 28, 30. Yeah.
But see, I do remodeling with annuloplasty, so I'm a different school of, but again, I don't want to get, I think this is a stale debate. It's not really about remodeling versus reimplantation. We are all doing the same operation in that the principles we're following are all the same. We're trying to recreate root geometry, we stabilize the basal ring, and we make sure that valve function is perfect at the end. My only question with regards to all of use techniques when you use large grafts, because I hear a lot of 34s and 30, is when you use a 34, you're not really downsizing the annulus at all in these patients, because then you'll end up, and so I think the annuloplasty effect is by the number of sutures that you put around correct? As opposed then by the size of your graft.
Yeah.
And so I think a point for people who are listening is if you're going to do a reimplantation and you're going to use a large graft, don't just put 3 sutures or 6 sutures, because that's not going to reduce the size of that annulus effectively. You need to be using, I don't do this operation, I use an annuloplasty, so the size of my ring determines the size of the annulus, and it's independent of the size of the graft I use for my roots. But when both are the same size, you really have to be thoughtful about if you're going to use a large ring, maybe use more sutures, because that's your cinching effect.
Yeah, you are right. It's an important point. Yeah, we use 9 sutures, for example, in Marfan patients, just to stabilize the annulus and to distribute all the forces in the annulus. What you can do is just in the proximal part of the graft, just reduce with some stitches, and then you pass the enough suture. Yeah, I agree that you can do 3 or 4 sutures.
So what we do is, I use 34 graft very frequently for male and 32 for female. We placate first to 30 millimeter. Then I put 12 stitches around the basal ring and uniformly make the basal ring smaller. Most time, probably it's about 22 to 25 is this range.
But see, that's the key, Bo. That's what you said. Forget the plication. It's the 12 sutures is what makes your annulus small. You could put a 40 ring. If you have 12 sutures, it's going to be tight. That's the key.
I don't tie around the higa. I just flat the graft. I just don't purstring the kink the graft because I already make it smaller. I don't need to tie it around the higa.
True step for graduate.
Yeah, it's exactly what we do.
Yeah. And see, if you do a remodeling with annuloplasty, then it's a different story, because then the ring that you choose based on what annular diameter you want at the end, and that's an independent decision of what sinotubular junction you want and what sinuses you want. This is the size of the graft. The ring itself, you can use a 28 ring and a 30 graft. You can use a 30 ring and a 28 graft. It really depends on geometric height, like Bo was saying. It depends on the severity of AI. It depends on the body surface area of the patient. It depends on preoperative aortic annular diameter. All of this has to be taken into consideration to determine what size annulus you want at the end, which ultimately should be something rather physiological, somewhere around 22 to 25 millimeters is where you want to end up. So probably around 28 to 30 millimeters is the size of the ring, and typically a 28 graft is the size of the
But also, I think the main take-home message is that annular stabilization has to be circumferential. Like the 3 sutures just doesn't work, especially in genetic patients. We know it failed in Lois Dietz patients with the Hopkins data, and we know it's not appropriate. But for bicuspid valves also, it's exactly what you said. It's the distribution of how you're plicating the annulus. And if you're trying to make the valve closer to 180, like the distribution of those sutures and where they go into the graft to help remodel, that is very important.
So when you do a valve repair, and not a David, just a valve repair, do you use all of you perform annuloplasty? What kind of annuloplasty do you do?
So I do annuloplasty when the basal ring is above 25, or especially above 27, I bring it down below 25. If I do annuloplasty, I do same as David's 12 stitches. The basal ring, I put most of them use 30 graft and bring it down to like between 20 to 25 millimeters to stabilize the annulus, the basal ring.
I have used 2 techniques. The stitch around the annulus from outside, it's like a safer technique. And also the technique just from inside, maybe 6-8 sutures, and outside it's like a ring, but not a ring, a cylinder of Dacron graft. For me, the second one stabilizes more the annulus than. For me, the problem of a stitch is about the durability of just a stitch around the annulus. I don't know in 10, 15 years, because, for example, in the Vega annuloplasty, for tricuspid valve, we have shown that it's not a durable technique, and in the left outflow tract, I don't know the durability of just only suture. That's my fear about this technique.
I share your concerns, and I do exactly what Bo said. In external annuloplasty for aortic valve repair, I don't use the 12. I use 6, and find that just as long as you tighten the Dacron band or the ring, whatever you use, an infinity band, all you need is really the band more than the actual 12 sutures. I just find it a little bit easier to take just 6 sutures out.
Ismail?
Well, for the isolated repair, I use a Dacron ring that I cut into an open band, and you go under the coronaries. The real challenge is really just because these are bicuspid patients. The real challenge is to do a deep dissection in the RV portion and under the right coronary. And there's often quite a bit of distance between the basal ring and the aortoventricular junction there. And you have to do a real deep dissection into the muscle, often enough getting into the right ventricle, which you can repair with a 4-Proline. But it's really important to go that deep if you want the annuloplasty to actually do what it's meant to do. And I always say that isolated bicuspid repair is 90% annuloplasty and 10% leaflet repair. Putting a couple of plication sutures on the leaflets to make them, that everybody can do. The annuloplasty is what will make the repair last. The suture on the leaflet is what will make it work in the OR. But the patients will come back if the annuloplasty is not good. So it's very important to, and in those instances, because the annuloplasty is so critical, I use continuous suture in the muscle portion of the annulus to really bring it in and to stabilize it as much as I can, and just a couple of sutures in the fibrous portion. So it ends up being usually about 7 or 8 sutures instead of just 6 sutures when I put a circular ring. The reason being that the ring, when you open it as a band, it loses its complete. From an engineering standpoint, it loses its perfect strength, and it can actually open a bit. Engineers say this. So I'm a little more nervous when I use this operator. And the data, that's why some groups have gone to just do valve sparing in all patients. I don't think that's a wise approach. I think if the root is not dilated, it's still safer to do a valve repair and annuloplasty, but the annuloplasty has to be very carefully planned and thought out.
Yeah. I have a low threshold, I would say, to do a valve sparing, just especially in the bicuspid with the huge annulus. If the root's like in the low 40s and stuff, it's for me it's easier, it's more reliable. I know I'm going to get deep enough. The issue is like with the Gore-Tex suture, I don't have any experience with it. It's actually getting deep enough and robust enough to have a good circumferential annuloplasty. I've never done internal annuloplasty ever. I don't think it works personally, but for me, earlier, the low threshold to do reimplantation. Otherwise, make sure if you're going to do isolated repair that you're getting deep enough to do a circumferential, robust annuloplasty.
Nice. And one question when you put a band for, in the annuloplasty, you have to take care with the coronary ostia, because if you don't put a suture deep enough, the band can compress the coronary ostia. And it's important for surgeons that are starting these techniques.
What about the caliper? Does anyone use Scheffer's caliper? I saw it in the videos.
Yeah,
I know you do it.
What is it?
The Scheffer's caliper.
Yeah, I use caliper. I think it's important as a concept. The concept is that you have to have enough effective height for sure the durability of the leaflets, and I think it's crucial, mostly in starting repairing programs. When you have experience in these techniques, sometimes you just look in the valve, you know that it's okay, and you don't have to put more stitches. And sometimes with caliper, you should need more stitches, but you can't do that because the leaflet can be stressed. But I think it's a very useful tool.
Yeah, I think Alberto said it exactly right. I think the concept is what you're chasing, and this is a useful tool to standardize the concept of, do I have enough effective height or not? I think it's very useful when you're starting, particularly when your eyes are not quite trained, to have a more objective measure of not just the actual effective height, but also the relative effective heights of all three leaflets. But the word of caution, I would say, is it can lead you, like you said, to do more than you should sometimes. And it really, the caliper, depending on how you angle it, you can under or overestimate the effective height and find yourself adding sutures, which will then put more tension on the leaflet. So it's important to also not be dogmatic about 9 millimeters at all costs. Sometimes you have to have a bit of
So moving on to the next video, we have Dr. Ouzounian's Y enlargement technique. And so I wanted to ask you, before the video and everything, how did this technique occur to you? How do you start it?
I listened to Tyron David one lecture. He said, how did he start the David procedure? He said, one time he looked at the beautiful leaflets. I just don't want to cut it out. So how can we save it, right? So, and you always want to do best for the patient and do better. What I did, the case come to me is I did a case, an old lady who had a mechanical valve and bicuspid aortic valve, came to me not aneurysm. Had a 25 size mechanical valve. I took it out. And then because of scarring everything, I put the valve in, size it, and I can only put a 23 tissue valve. People say she's 75 now. She was like 30 years ago, 25, 75, 23, perfect for her. But I think I cannot give her a discount. And I said, do enlargement. And then during the process of taking the mechanical valve out, it damages the aortic mitral curtain at the top a little bit. So normally, we see that all the time. You patch it. I know I just patch it. But how do you do the enlargement? First, I cut the left non-commercial open. There was a hole there, but this way, and I cannot patch it, put it back together anymore. I patch a small angle come up. I was easily put a 25 in. So wow, I said this is so much bigger. And I said I was thinking how far I can go both ways. And my early career, the only cases I did is type A dissection and endocarditis. Nobody wanted. I did all of them. So with the endocarditis, it destroyed the aortic mitral curtain very frequently. That's not a big deal, but they never destroy the fibrous triangle, so dense tissue. I think I can go as far as the fibrous triangle. So first case I had that idea. First case I think I just go this far. And I had a lady had a pancreatic transplant, renal transplant, all these things come. Very small lady, like 17, 18 millimeter annulus. So at the most hold the 19 valve. I just went both sides far. And I was put a 25, 23 valve in. I was very happy. That's how it started.
When can you not do this
operation? Oh, that's a great question. I had one case I couldn't do it. Is a 82-year-old guy. He had a TIVA and he had a pseudomonas and the carditis that came to me. So I took the TIVA valve out. The root looked okay. I was thinking about enlarging, but I felt that the aortic mitral curtains completely full thickness calcified. And then the mitral annulus is calcified too, so I cannot cut down, I have nothing to sew to. I think that's the only contraindication I couldn't do it. It's the full thickness calcification of the aortic mitral curtain. You have nothing to sew to. So don't do it if you see that. Yeah.
What about the ostium? Because sometimes I'm worried about the left ostium being like too much in the commissure, and the enlargement can, kink it or damage it.
Yeah, so that's a very common question. We cut down to the left side, to the left fibrous triangle partially. If you look at that, half of the left coronary sinus is mobile, but the corner is still anchored to that, the position relative to the left fibrous triangle is the same. And the patch push posteriorly to transverse sinus really doesn't change the trajectory of the left main at all. We have done 170 now. I have not had a single case of the coronary problem. I was worried about coronary at the beginning too. Every case I look at the coronary for the first 10, 15 cases, but after I never look at it anymore. And I don't look at mitral anymore. Mitral have no problem either. Yeah.
About the material, what do you all use as material for enlargements? So Dacron graft, because some people uses Gore-Tex, some people uses pericardial patch.
Yeah, I think you can pretty much use all material. I use HemoShield patch because one single patch is cheaper and it's very useful in patch it. And for if I do ascending replacement, I have Dacron graft, HemoShield or whatever gel wave graft ready, I just use that graft because that you can replace it, what you can replace with that. But on bone pericardial patch just calcify. I don't use that for anything now. I use one in the carditis patient, but I don't use it anymore. I just use this synthetic material.
What about you, Marai? What do you use usually?
When I do it, which
Any enlargement? Do you use
bovine pericardium, it might calcify, but I think I don't know if the other materials are going to calcify too.
I like also pericardial because it's, I don't know, I can mobilize it like easily. What about you?
I mean, if I had to do it, I would use a Dacron patch. I think it just takes away the calcification portion. It just sits there. It's easy. If you have to go back, you have that layer on top of it. You can just deal, So why not use Dacron? We use it for aorta all the time. I think it's better than pericardium, in my opinion. That being said, I think Bo's technique is great because it's reproducible. But I would remind people if the patient is born even with an 18 millimeter annulus, if they've made it to adulthood, I don't think that the patients need to have these techniques done if we do a root replacement with either a stentless valve or a Ross or a homograft. So depending on the age of the patient, if the patient is young, a Ross procedure does the trick very well. And if the patient is over the age of 65, I think a freestyle does a great job in that sense because the LVOT is appropriate for the patient. We love to say they have a small annulus. They actually don't. They have an appropriate annulus. Our stented valves are just not well designed for people on the lower end of the normal spectrum. And so it's one alternative to doing so is to just put a freestyle root. And if you put it in patients over 65, it's pretty much a definitive operation in the majority of cases. But again, I think that being said, if you don't want to do root procedure or the coronaries are calcified, it's an extremely useful tool.
Yeah, it's the stented part of the valve that's the obstructive.
That's the issue.
That's the issue in people with small annulus, and it's only if you're replacing it with a stented valve that this is where we really do need to get a larger valve in.
No, your technique is fantastic, Bo. I think it's a great tool to have. Going up 2 or 3 sizes though, I find that the valve kind of sits,
How? Don't oversize too much or you're going to end up on my shoulder.
My concern with that is that, and I'm just paraphrasing Tyrone when I say that the only way that you can truly enlarge the LVOT is by doing a cono.
Yeah.
Anything else, you're treating your head more than the patient's outflow tract.
So
And a cono should never be done in an adult. I mean, that I think is only in babies with congenital AS. I think past the age of 1, a cono has no role in adult surgery, in my opinion, in my humble opinion.
yeah, I wanted to address those two issues. Comes up so frequently. Number one is candid. I scanned all my patients post-op 3 months. I had 170 cases now. The valve sitting actually very well, perpendicular blood flow. I published all the videos and the publishing species against the valve because when you sew it, you lift the patch back like this, you see it's tilted. But when you sit it down, put it there, pressurize the patch going posteriorly, it sits very nicely. Even 3, 4 valve sizes. You can look at my publications in the GTCPS seminar, all the videos, and I scanned everybody except one patient that was tilted. That patient was, I don't know why, he had the inclusion freestyle, and then somebody did the valve involving the freestyle. I took the inclusion freestyle out, it's 23, I enlarged 29, that valve was killed a little bit. I don't know why, but only, I think the inclusion freestyle may distort the root a little bit. That's number one question. Second question, the LVOT question. You guys both have the same thing. I mean, Ismail asked, said LVOT is normal, even though it's 17, 19. My LVOT for 2021, that's normal for me because that area is about 3-4 centimeters square is normal. Like if you come to me with aortic valve stenosis, and your aortic is small, just valves calcified. Right? We take it out, we put another valve in you. Your aortic is still normal. There's no need to enlarge your normal LVOT if it's not narrowed. The problem is that you mentioned the stented valve, the orifice is half of the size if we don't enlarge upsize it. And we did all the studies. We upsize 3 to 4 valve sizes, found out that the CT measurement before surgery and after surgery is exactly the same. You have the up 3, 4 valve sizes. Then you can really match the annular size, the basal ring size. That's why I did that. So, and people think that's too aggressive, but I just think you need 3 valve sizes. Because if you look at the FDA study, the label of the valve, C23 and 29 valve, the real opening is only 23 millimeters.
But Bo, is there an age you just do a freestyle instead of?
Oh yeah, that's another great question. We did a 3,500 freestyle in our center. We used to, that's deep is always the idea. Freestyle is great operation, but freestyle from 29 freestyle, look at the label. In the opening is 25. Same thing, 25, 23. Same thing, they are still not the same size we labeled. So if you want to do total root, do a freestyle, if you measure 19, you don't put a 19 freestyle. You upsize 23, 25. You need the upsize of freestyle. You should make sure the freestyle openings match the patient.
But the gradients are single digit off.
Yeah. We shy away from freestyle. Now we stop using freestyle. We are the biggest one using freestyle. The reason not doing it is freestyle is not good for valving for TAVR because the small the defects can cover the corners. Especially a large one, we had the valve herniated in the LVOT, so we stopped using freestyle. Yeah,
I think it's a fantastic operation, your technique, and I agree with Ismail that, but not all the patient with a small annulus should have this technique, but I think it's very useful. And with respect to your comment, I think it's true that sometimes the prosthesis looks like some of liquid, but the important point is that gradients are very low, and you can put a higher prosthesis. So I think it's a very nice technique to. Yeah.
What is the minimum size that you normally implant?
25.
25.
And the 70-80% the patient gets 29.
Okay, that was my next question. Really. And now that we're talking about freestyle, we're going to move on to the last video, which is a ROS procedure performed by Gustavo Prieto, who is not here. And he did an alternative of the homograft because he lives in Colombia and we do not have many homografts right now. And he used freestyle in the pulmonary valve. So, comments from the ROS procedure expert.
I think it's a great. I think the benefit of the real benefit of the ROS, if you think of survival, and hemodynamics and valve-related complications, is having that living pulmonary valve in the aortic position, and that's really the survival valve is the aortic valve. The pulmonary valve is not a survival valve. Pulmonary valve is a conduit to just get the blood through. So. Ideally, you would use a pulmonary homograft, but if the only alternative is to use a freestyle, I think it is still worth doing a ROS with a freestyle as opposed to saying, we don't have homografts, we're just going to put a prosthetic valve in the aortic position. So I think it's a great option. It has been used. There is experience. There are French publications. Jochen Schaefer's presented at the AATS just a few months ago, his experience in, I think, 76 patients. With a mean follow-up of somewhere around 7.5 years with very good results. So at least in the first decade, it's a very reliable option. In the second decade, the data, we still need to know, but that's one option. You can put a prosthetic valve in a Dacron graft and use it as a valve conduit and put the valve in the middle so that you can bevel the Dacron proximally and distally and just have it there. That's also a good valve, transcatheter option in the future if need be. So all these options are good options if it allows young people to get a ROS.
What about you? What do you think?
Yeah, we use homografts obviously, but they are difficult to access and expensive, especially globally, I think we need to have some solutions, and I think it'll be interesting to have some new, bioengineered valved conduits for the right side. This is an area of potential, scientific
Research,
progress
yes.
and research. Yeah.
Juan Pablo.
We use holografts, and I agree that it's very hard to come by them, particularly the decellularized ones. But I've never used the freestyle in the pulmonic position. As the only advantage of getting older is you start recognizing patterns, right? and we all know that 8 years, just about any bioprocedure will last 8 years, right? It's after 8 years that you start seeing that fall off. So it'll be interesting to see what happens. The reason we stopped using freestyles is because of the difficulty in reoperation. That's really my concern. Of course, on the right side, you're not going to have as much trouble. You should not have as much trouble, and particularly if you're using either a pericardial patch or a Dacron patch in order to get that rigid,
Yes.
chimney structure to sit appropriately for the outflow tract.
He uses in the video a scarf of pericardium
Right.
For the outflow. Yeah.
Yeah. So that'll calcify as well. It's going to be interesting to see what happens down the line and how you can deal with those. But I agree. The priority is to get that living valve into the aortic position. If you can do that, and the freestyle allows you to do that, I think it's a great option for countries that don't have access to holografts.
What do you think?
I do agree. What do you have? Use what you have to make a good operation.
Well, I don't have nothing to say to all this, but I like to ask one question about the prevention of autograft dilation. What tips do you suggest to surgeons just to avoid, because this is the big problem more than the right side?
Yeah, I think it's a combination of factors, technical factors and post-operative management. The technical factors are to really leave very little muscle under that pulmonary autograft valve, because that muscle is now dead, devascularized, and it provides no support to the valve itself. So cut it very short, make sure the valve is implanted in the LVOT so that the native aortic annulus can provide support to that pulmonary valve. At the sinotubular junction, same thing. You trim the autograft, you leave no more than a couple of millimeters above the commissures. And if there's any mismatch between the aorta and the sinotubular junction, even if the aorta is not pathologically dilated, even if it's just 39 millimeters, 39 millimeters is far bigger than any normal sinotubular junction. So don't put them together, otherwise you're just stretching the autograft right away, and that sets it up for failure. So I like to use a very short interposition graft, Dacron graft, 26 or 28 millimeters. Put the circular portion on the sinotubular junction, so you've fixed that, and then you bevel it just 1 centimeter distally and anastomose it to the native ascending aorta. So you don't have a long Dacron graft, but what you've done is separated these two from each other. And you fix, so you have a sinotubular junction and the annulus are stabilized. And for the sinuses, you can use a native aortic jacket, but most importantly, it's post-operative blood pressure control. And the idea is the concept is you're taking a valve that is coming from a 30 millimeter systolic pressure to 120 millimeter systolic pressure. You don't want that to go to 150, 160, 170, etc. And so we're very aggressive with beta blockade, plus other agents if needed, to decrease the DPDT on the autograft. And we try to keep the systolics below 110, 115 for the first year after surgery.
For the first year.
You control it with the MAPA? How do you say?
Yeah, well, not continuous MAPA, but we do have them buy a blood pressure cuff at home, and they communicate with us continuously. And in our experience, about 2/3 of the patients will need some adjustments within the first 3-4 weeks after discharge. After that, it's steady state. But when they leave the hospital with, systolic 112, it's no guarantee that it will stay that way. And 2/3 of the patients will start to creep up as they get more. So you need to have this continuous feedback loop.
Let me ask you, if I may ask a question.
Yeah.
And I think covers everything that we've been discussing, but 44-year-old with a 20 or 21 millimeter LVOT, who's had a couple of operations in the past for congenital aortic stenosis. You take that patient for a ROS and you find that the pulmonic valve is not usable. What would you use in that case? 44-year-old.
Yeah.
And 21, it's an appropriate LVOT.
Yeah.
Are we having a debate all the time?
No. There's no debate because again, what I'm saying is all these techniques are complementary.
Right.
And in a case like this, I would consider a freestyle, but in a 44-year-old, I wouldn't want to put a freestyle because it's going to fail and it's going to calcify. The redo is going to be painful. Same for a homograft. I would certainly do Bow's root enlargement technique. I think that's at that point, that's really, at least in my hands, the best way I can deal with this. I would have a higher threshold to accepting a pulmonary valve if it's bicuspid, if I'm not too sure about the fenestrations in a case like this, as opposed to if it's a 58-year-old who comes for AS with a normal sized annulus. Do you know what I mean?
Yeah, absolutely. What about the idea of sewing in a bigger valve into a larger graft, as you do it, as opposed to connect? And does that have any effect on your gradients?
If there's two ways. If the annulus, the basal range is 21, what I do is I make my own graft. I will use a 26 graft, put a 27 valve into the valsalva portion, and sew the 26 collar to a 21 annulus because outside everything it matches very well. That's how we enlarge with the total root replacement. Same idea. You don't put a 21 pre-made root there. The valve is too small. So 27 valve has an opening in the diameter. It's about 22, 21, 22 matches the patient's annulus. And if we want to use pre-made the connector, that's I don't use that because I don't remember that name. So some surgeons actually do a Y-Incision, do an enlargement, make that portion the root is much bigger than dump another 27 pre-made valve in the enlarged root. That's another way to do it.
Okay, so incredibly, it's been an hour already, and we need to finish this incredible discussion with this seriously luxury panel. I am so grateful for you all coming here and being so willing to have this discussion. Thank you very much to all of you. We're going to just close it. Any final closing remark from anyone?
No, I think the key in root surgery in general is volume and experience. It's just doing it all the time, seeing the pathology, becoming comfortable with all of the principles, and keeping the principles in mind rather than the minutia. I think gets you to the finish line.
Thank you.
Closing remarks.
I think for the root procedure, as Ismail also pointed out, surgeons have to know the normal anatomy of the root, from the LVOT, basal ring, the sinus, STJ, the cuspus, the interleafal triangle, like the Robert Anderson's paper about the surgical anatomy of the root. That's very important paper to read. During the education, you're on fellowship residency, nobody talks about the root anatomy at all. If we want to be an aortic root surgeon, you really need to understand the anatomy and physiology of the root.
Lorena, thank you for organizing this. I hope that people watching will benefit. But
I'm pretty sure everyone will watch.
It was very fun to put us together.
Yeah, you will do the for you to do. Yeah.
Thank you, Lorena.
Thank you.
So thank you very much for watching, and let's see each other another time. Bye.
Bye. Bye.